Okay.
Good. So, right. So, do I unmute now?
Yeah, yeah. Do you think?
Right. So, nice. So, we going into this morning, as promised, our interview with Dr. Peter A. McCullough, and he hails from Dallas. Dr. Peter McCullough, good morning to you. And Dr. Peter McCullough is an internist, cardiologist, epidemiologist. He manages common infectious diseases as well as the cardiovascular complications of both the viral infection and injuries developing after the COVID-19 vaccine in Dallas, Texas, USA. Since the outset of the pandemic, Dr. McCullough has been a leader in the medical response to the COVID-19 disaster and has published pathophysiological basis and rationale for early outpatient treatment of SARS-CoV-2 COVID-19 infection, the first synthesis of sequenced multi-drug treatment of ambulatory patients infected with SARS-CoV-2 in the American Journal of Medicine, and subsequently updated in reviews in cardiovascular medicine. He has 51 peer-reviewed publications on the infection and has commented extensively on the medical response to the COVID-19 crisis in The Hill America Out Loud and on Fox News Channel. On November 19, 2020, Dr. McCullough testified in the U.S. Senate Committee on Homeland Security and Governmental Affairs, and throughout 2021 in the Texas Senate Committee on Health and Human Services, Colorado General Assembly, New Hampshire Senate, and South Carolina Senate concerning many aspects of the pandemic response. Dr. McCullough has had 21 months of dedicated academic and clinical efforts in combating the SARS-CoV-2 virus, and in doing so, has reviewed thousands of reports, participated in scientific congresses, group discussions, press releases, and has been considered among the world's experts on COVID-19. Good morning to you, Dr.
Good morning.
And a very good morning to you. I am Robert Amar, and you are speaking to us on M1047 in Trinidad and Tobago. And we want to say
we are happy to have
thank you very much for taking the time out on your Thanksgiving Day to spend some of this time to try to edify our people in Trinidad and Tobago about something that you have a wealth of experience. Welcome to Trinidad and Tobago via the internet.
Thank you.
Tell us a little bit, Doc, about what's happening in the world today. I mean, what's the biggest issue that the world has to deal with? I mean, the universe has so much misrepresentation of information, so much, I have to say, false in details. Where do we start to correct this misinformation so that we could really start doing what is best for mankind?
We need to have oversight over our public health agencies. They have disseminated a massive amount of misinformation, and SARS-CoV-2 virus and COVID-19 infection must be treated early so patients don't suffer, become hospitalized, or die. So we need immediate oversight from external expert physicians over our public health agencies and start to vet the information coming out so no more misleading statements are made from our public health agencies.
What is considered early treatment? How do you get it early? I mean, you know, we have some experiences over the last 48 hours with some people we know personally. One is an elderly woman and the other one is a younger person. The elderly woman was showing signs. I mean, what are the early signs that you have to lock on to make sure you take this multi-treatment to help you from suffering?
Nasal congestion, headache, loss of taste and smell, fever. Those are the cardinal features. And one has to recognize that that could be COVID-19 and get a rapid test.
If somebody is tested positive, but they have no symptoms, and are not treated, because you see we have to catch this at an early stage, but they are positive, but they have none of these symptoms, so they're not treated, they will not reach into that situation. Is it possible? Is that possible? Doc? Dr. McAuliffe?
Someone is asymptomatic, they should not undergo any testing because it's likely the test will be false positive.
Wow.
And how do we get around this issue that everybody keeps using still the PCR test as the Bible for advocating? In Trinidad and Tobago, we have seen every day over 500 people testing positive, according to our Ministry of Health, and they are still using the PCR test. Is that test really a fair test to advocate someone who is COVID positive?
Well, 500 cases is a pretty low number. So my advice would be to use confirmatory testing and then a PCR cycle threshold of less than 28. Our CDC advises that. So cycle thresholds less than 28 and confirm it with an antigen test, and that would be a bona fide case of COVID-19. If it doesn't meet those standards, it's probably a false positive.
So the antigen test is a must.
You can use it for confirmation. You can use it for standalone testing if someone's asymptomatic. But what you want to do is you want to eliminate asymptomatic false positives.
And the threshold has to be 28. So the Ministry of Health in Trinidad and Tobago should make sure that all the testing stations in this country conform to a standard.
That's correct. I mean, our CDC says that cycle thresholds above 28 are likely to yield false positives.
Is it fair to say that after 5 days, the virus in the human body cannot be spread?
No, that's not true. It can be spread for up to 14 days with no treatment. Early treatment shortens the duration of spread to about 4 days.
Okay, so that is the key, as you say, which has been shared by a lot of other professionals all over the world, that we must catch this thing in the early stages if we want to stop death.
That's true. That's the only chance. The hospital is too late to try to save patients.
Yeah.
We can use a variety of drugs, about 4 to 6 drugs at home, particularly in elderly people, to reduce the risk or eliminate the risk of hospitalization and death.
Is the drugs that you're suggesting something that has been peer-reviewed and published, or is this still a controversial situation? Because our Minister of Health in Trinidad and Tobago is anti-ivermectin
and hydroxychloroquine.
If it was controversial, as an expert doctor, I wouldn't use them. So I'm very confident that the evidence supports everything I'm going to tell you about early treatment.
So the bottom line is that most of these people, when they get those symptoms that you advocated earlier on, with the nasal and the fever and the loss of taste, if they start taking that concoction, if I call the word, at home, their potential to live is greater than even thinking about facing the hospital, because when they get to the hospital, it's already too late.
That's correct. Now, only people over age 50 with medical problems, and I think everybody over age 65 should receive treatment. Young people don't need any treatment because it's like having a mild upper respiratory infection. It's like a common cold for young people.
In terms of when we talk about these, like the variants, are there tests, confirmed tests for the variants? How do we know? How is our health experts confirming variants? Like somebody is suffering from a Delta variant and all of that.
The variants are determined by genomic sequencing, which is available in research labs and then in the public health service labs. But we don't have sequencing available for, commercially available tests.
Right.
But what we know is since the Delta variant infects patients who are vaccinated very easily, the vaccination program worldwide has basically made Delta the dominant strain. About 99% of cases are Delta. because it lives and thrives among the vaccinated.
You were talking about genomic testing, and you were saying it is not available in a general sense from a lab, from a doctor's office, or from some place.
Commercial,
In Trinidad and Tobago, I was reading something out of the British Journal that indicated that they only started doing genomic testing in March of 21. Is it how possible it is for a small country like Trinidad and Tobago to have genomic testing? Do you think small countries like ours will have that scientific capability?
Sure. The genetic testing platforms are widely available now, and they give confidence in the results. And because you have patients who took the vaccine in Trinidad, once you get to more than 25% of the population, the Delta variant will become the dominant variant. It's 99% of what we have in the United States, Israel, Europe, because the vaccine promotes the Delta variant.
Mm-hmm.
Is there any cure for that, Doc? After we get to that point where because in Trinidad, we have about 42% of our population that have gotten the jab.
Yeah, now you're stuck because you've vaccinated too many people. Once you get to over 25%, the Delta variant is consistent, has become the dominant strain right now because the vaccinated people pass it to one another.
And it means to say that our death toll in Trinidad and Tobago will definitely spike.
In every country where the vaccination rates have gone up, the COVID-19 problem has gotten worse.
Yeah. Is that equivalent to the vaccine shedding? Could you give us a little more details on that?
No, that's different than vaccine shedding. Mm-hmm. Shedding is when the spike protein alone is in secretions and it's thought to spread to one another. Shedding is probably a mild symptomatic syndrome of just close contact within about 4 weeks of vaccination. What we're talking about with making the epidemic worse is since the vaccines do not stop SARS-CoV-2 and the Delta variant has mutated to escape the form of the antibodies from the vaccines basically have made the problem worse worldwide.
You heard the Pfizer chairman or CEO say that he didn't take the jab yet and that he didn't want to jump the line. How do you feel about somebody who created something like that, making a statement like that?
We don't have to worry about a line for the vaccines. People stopped taking the vaccine in April of 2021. Once the news was known that people were dying after the vaccine and being injured and permanently disabled. So we have an oversupply of vaccines. No one wants them. He doesn't have to worry about jumping the line. If he wanted to take a vaccine, he would.
He would.
And the fact that he won't take the vaccine should make everybody very concerned.
Very concerned.
That there's a problem.
In our country, our administration and our health authorities make it seem to us that people dying after taking the vaccine is a myth and that everybody's dying from COVID. So that's just something that you just said, that when people realize that people were dying after the vaccine. But if I was to say that here, they'll say that I'm lying. People are not dying from taking the vaccine.
People are dying after the vaccine in large numbers. The CDC US VAERS system has over 18,000 deaths. About half of those are domestic. The deaths occur within 48 hours in at least half of the cases. Within a week in 80% of cases. The same thing is seen in the UK yellow card system and in the Europe UDRA system. So it's clear that the vaccines have a very high case fatality rate, which is really unacceptable. We should not have people voluntarily taking a vaccine and then dying within a few days.
Within the Pfizer document that they presented for the caregivers to administer, there was nothing in it talking about, what should I call it? The way the vaccine, the way the jab is to be administered. In doctors, just in layman's terms for people to understand, because we don't have a lot of people in Trinidad and Tobago that have the scientific experience. But when they stick the needle in your hand, they're supposed to pull back on the syringe in order to make sure they don't hit a vein, because it's supposed to go into your muscle. Just suppose that this, if this went into your vein instead of into your muscle, what happens?
It's possible there could be more rapid dissemination of the lipid nanoparticles, but they're so lipophilic, and we know from the biodistribution studies from that Pfizer did for the Japanese and animals. We know from human autopsy studies and studies from the Chinese in other animal models with other lipid nanoparticles that I can tell you after vaccination, these products go everywhere in the body, the brain, the heart, the ovaries, the testicles, the bone marrow. They widely distribute, and when they dump their payload of genetic material and cause a mosaic of cells to start producing the dangerous spike protein, this 1200 amino acid protein damages cells, causes inflammation within tissues, and then Ogata and colleagues from Harvard shows it widely distributes in blood even up to 29 days after the vaccine. The messenger RNA may stay in the human body for many months after that.
Is the Sinopharm built along the same basis as the Pfizer?
No, the Sinopharm or CoronaVac vaccine is a killed virus vaccine. So it's very different. There's no genetic manipulation of cells. But unfortunately, the CoronaVac vaccine has very low protection, far less than 50%, and it's probably not worth taking a shot.
From your knowledge and your qualifications and all these things, do you think that so what is it? Is this a virus or a bacteria? And
it's a virus.
Right. And why is it that we are not allowed to do autopsies?
The original concern is that an autopsy would further spread the virus, but fortunately there's been enough autopsies done both in the US and in Europe for us to understand that the viral infection is fatal. The common pathway to death is microthrombosis or blood clots that occur throughout the body, and that we know with a natural infection that indeed the virus does cause the death. There's really low rates of superinfection from other bacteria or other pathogens. This is very unlike influenza. The most common way that someone dies with influenza is with a secondary staphylococcal infection, which we have not seen with SARS-CoV-2.
Right.
In regards to Chiron, you were speaking earlier on, and you did make the point that people under a particular age, there was no necessity. Is this imposition on Chiron fair?
No, children have a very mild syndrome, and it doesn't warrant vaccination. So given the risks of death, heart inflammation called myocarditis, the neurologic injuries that happen with the vaccine, even if there's one case of myocarditis, it's too many
much, yeah.
Because the virus is so mild. So children should not receive the vaccine.
This issue of women who now, through their menstrual system, has started to have significant blood loss and not having their cycle back to normal.
Also the miscarriages. We have had testimonies of persons having miscarriages like less than 3 days after having the vaccine.
It's biologically plausible that the spike protein can damage the placenta. The spike protein damages red blood cells, causes blood clotting. About 2 weeks later, it can cause a bleeding disorder called vaccine-induced thrombocytopenic purpura, VITT. Wow. And so the FDA strictly did not allow pregnant women to be involved in the randomized trials. And we should follow that practice in public administration. Pregnant women, under no circumstances, should receive the vaccine.
For a small country like ours, Doc, I know you say the numbers wasn't high, but remember our population is only 1.2 million people. And basically, to us, when you take that and you extrapolate it to 300 million people like in the Americas, we kind of rival in you guys with regards to the numbers of people that are being shown as infected. And our death toll has climbed from almost zero to between 17 and 25 per day for the last 10 days.
Well, we are greatly concerned we are going to go into another wave, especially in the United States, because the vaccines don't last 6 months. So the majority of people who took the vaccine, they had some very modest protection. And what's happened is the time limit of 6 months has run out, and now the virus has mutated to the Delta variant, which is not stopped by the vaccine. So we're going to have another wave in the United States, and it's going to be among our senior citizens.
In terms of the boosters, you're over there. Y'all have reached what number? Is it the third or the fourth?
This is our third wave. We had one wave before the vaccines, and we crushed that with our early push on treatment in the historic U.S. Senate hearings, which I participated with. We had a second large wave, which was due to the vaccines. That's the Delta wave. And now we're going to have a third wave.
Are we going to see doctors like yourself come together and have a forum on the internet to try to educate and inform the world doctors as to the best practices that should be implemented to prevent mankind's destruction?
Independent forums are happening, and there's independent organizations, the Truth for Health Foundation, American Frontline Doctors, Frontline Critical Care Consortiums, the Unity for COVID Project. But what we need is in the government agencies to really step in. The government agencies have been absent on early treatment. They've been absent on mitigating the risks of the vaccine. So our public health agencies have really let us down.
In the Japanese model, we were hearing that their, of course, jab rate is, I think, 60% or more. And they are giving an impression, at least one doctor was giving an impression, that the ivermectin together with that is what was a factor in the reduction of mortality. Is that a fair assumption?
The vaccines have a very small influence on mortality. In a large paper by Cohn and colleagues from the US VA system, the vaccines for a few months reduced mortality by 1 or 2%. What's made the big difference in Japan is the widespread use of ivermectin. We saw the same thing in Mexico City, South America, India, and elsewhere. So ivermectin is what makes the big impact.
The alternate that Pfizer just produced, another person compared it, and it seems there are significant similarities. Do you agree with that? That there are similarities?
The new drug.
No, the Merck drug is molnupiravir. It's a polymerase inhibitor. It's very similar to favipiravir, which is also used in Japan and Russia and several states in India. So the ivermectin is very different. Ivermectin has multiple mechanisms of action, and so we know that ivermectin works to block the spike protein. It blocks nuclear entry of the virus into the cell, and it reduces a variety of cell signaling factors. So ivermectin does a lot more than the Merck drug.
Have they stopped the sale of ivermectin in the United States of America? Is it prescription, or can you go and get it off the counter?
It's not over the counter, and it should be freely prescribed and dispensed, but the American Medical Association in the United States, as of early September, launched an initiative to abolish ivermectin in the United States. So the American Medical Association is working through the pharmacists to try to block ivermectin to people suffering with COVID-19. The Association of American Physicians and Surgeons, which supports early treatment, has sent a cease and desist letter to the American Medical Association to stop this activity, since it's leading to patient harm and death.
In your function, seeing and just hearing that and knowing what it is working and what it is working for your patients and all of that, and seeing that resistance that is coming from the United States and the administration, what are you thinking is happening?
I think at this point in time, the public health agencies are under-resourced. They need to bring in new experts to lead the nation and the world out of this problem. We need teams of experts to come up with public health methods to reduce the spread of the disease, largely using oral and nasal decontamination approaches like dilute povidone iodine and dilute hydrogen peroxide. We need experts on early treatment to put together the widespread treatment protocols and get treatment kits out to high-risk patients, and also intravenous administration of monoclonal antibodies. We need a separate team to improve in-hospital care. And then finally, we need a team to work on better vaccines. We will need some vaccines probably for our people who are very old, living in old age homes. But vaccines beyond that group should not be done because it's just going to promote more resistant viruses. So at this point in time, our public health agencies should drop the vaccine program and start with this 4-pillar approach. I presented that to the U.S. and the U.S. Senate in November of 2020.
Is that a document that you could send to us, Doc, by email?
Yes, I'd be happy to.
I would love you to send it to us because I'd love to send that to our Prime Minister and the Minister of Health of Trinidad and Tobago, because I think, you are saying the right thing. Trinidad and Tobago needs to, and this has been said by a lot of people in the country, that we need to bring in a whole new team of people because the team that is there doesn't seem to be doing the job in the best interest. Now, it leads me to a kind of semi-final question. I don't know if Ruby has anything to say again, but how do you reflect the doctors who have taken the Hippocratic Oath, in which it says that they will do what is in the best interest of their patients, knowing fully well that they have seen signs of this ivermectin working, especially if you catch the person in the early time, and the experiences we see in Japan and other places? How do you feel about those doctors? Are they failing to accept their role after they have taken this Hippocratic Oath?
Yes, they're failing to fulfill their responsibility as physicians. Physicians should always respond to patients who have potentially fatal illnesses and do the best they can with the medications at hand. We've shown that it takes about 4 to 6 medications. No single drug is necessary nor sufficient, so it can be treated without ivermectin, without hydroxychloroquine, but patients should receive about 4 to 6 drugs in combination to reduce the intensity and duration of symptoms and reduce these risks of hospitalization and death. All high-risk patients deserve early treatment.
Yeah. My last question is just for clarity. What is a high-risk person at high risk to get the COVID-19?
Well, high risk in terms of when they get COVID-19, we're talking about the risk of hospitalization and death. So it's everybody over age 65, and then it's people over age 50 who have medical problems such as obesity, diabetes, high blood pressure, heart disease, lung disease, kidney disease, and cancer.
Can a blood test tell you whether or not you have your own natural immunity built in? Can you do a blood test to see whether or not your immunity is able to fight this disease?
Natural immunity is important because once somebody has had the infection, they can't get it a second time. So natural immunity is robust, complete, and durable. People who have had COVID-19, they don't need to wear masks anymore. They don't need to take vaccines. It's over with. What we know is that if someone's had COVID-19 and the case is well documented with the PCR antigen testing, then no further testing for immunity is needed. But in the case you mentioned, if someone did not have a well-documented case, they can get an antibody test by any of the big laboratory companies, Quest, Abbott, Roche, LabCorp. They have high-quality assays, and if those are positive, that confers immunity. And then lastly, if the antibodies are not positive, a T cell test can be done. It's called T-Detect. And this can be ordered on the internet at tdetect.com. And then the test is done LabCorp, and the blood will be processed, and it can look for T cell changes that can immunity.
Right. So judging from that, how do you explain somebody contracting the disease more than once?
It doesn't happen. What people get confused about is the test is false positive for a long time after they have COVID, but they don't get the illness over and over again. Once somebody has COVID, they should never get a second test.
Doc, here's the final one from me. How do you feel the world is heading? Are we heading for segregation?
The world is heading in the wrong direction because the vaccines have failed and they're not safe. And now, instead of stopping the vaccine program, what's happening is there's discrimination and segregation according to the vaccine, and people are getting COVID-19 anyway if they took the vaccine. So the world is heading into the wrong direction, all based on the vaccine. And to make matters worse, now the vaccine isn't given one time, but boosters are given every 6 months. So we know in those people who are accepting the vaccine, the spike protein will accumulate in the body and almost certainly lead to chronic disease. So we're going to have two groups of people. The best way to stay healthy is to decline the vaccine and hopefully get natural immunity after getting SARS-CoV-2 infection.
Dr. McCulloch, look, it was a great pleasure speaking with you this morning. I hope the people in Trinidad and Tobago would have learned from you. We will definitely
mainly the administration.
We will definitely take a recording of this program and send it to the Prime Minister of the country, because I think it's important, as you say, for the change to happen from governance. If the governance is not serious about saving the lives, then we have a serious problem. And I am sure that your information definitely will reach to them, whether they will take your suggestion, advice, and experience over the years and a year and a half that you have been there, and the wealth of your experience in the past is yet to be known, but we will keep you apprised of what's going on, and I look forward to getting a copy of the document.
Thank you.